In this video, we'll talk about pulmonary ventilation. Pulmonary ventilation is the movement of air between the atmosphere and the inside of your lungs. So it's inhalation and exhalation. And pulmonary ventilation means that air will flow from where it is a higher pressure to where it is a lower pressure. So the fact that you inhale and exhale is based on pressure changes, where air will flow into the lungs when the pressure in the lungs is lower than the pressure in the atmosphere, and out of the lungs when the pressure in the lungs is higher inside them than it is in the atmosphere. So changes in alveolar or lung pressure occur when the volume of the lungs change. So the pressure gradients that influence pulmonary ventilation are atmospheric pressure, the pressures of the gases in the atmosphere together, intrapulmonary pressure, which is the pressure inside of the alveoli or inside of the lungs, and intrapleural pressure, which is the pressure between the two serous membranes, the visceral and the parietal pleura, outside of the lungs that line them and help to keep them inflated. This also changes as you inhale and exhale, and there's fluid in that intrapleural space. So definitions of atmospheric and intrapulmonary pressure. Atmospheric pressure, again, molecules that make up the air. Intrapulmonary pressure within the alveoli. It rises and falls with inspiration and expiration. Equalizes with atmospheric pressure due to those pressure gradients reaching equilibrium. So when we relate pressure and volume, because the only way we're going to get pressure changes within the lungs, so the air will flow in and out based on that change of air flowing from high to low pressure, is to change the volume. So Boyle's law describes the relationship between pressure and volume, and that says that the volume of gas varies inversely with its pressure. And that means that if the volume goes up, the pressure goes down, and if the volume goes down, the pressure goes up. So you can see on this figure on the left side of the screen that you have a container with a piston that is making it closed and a pressure gauge. And the pressure is 1 atmosphere in this figure on the left, and the molecules shown in orange are bouncing around inside of the closed container. If we half the volume of that container from 1 liter to a half liter, when we move over to the figure on the right, we see that the pressure doubles. So we see here as the volume decreased in the container, the pressure increased, and the same thing is going to happen inside your lungs. If the volume decreases or the lung volume gets smaller, the pressure of the gas molecules inside of the lungs are going to rise, and vice versa. So let's relate this pressure volume change to the lungs. So breathing requires muscular activity and changes in chest size. And I like this depiction because it shows a slight movement of ribs. Ribs have an articulation or a joint with the transverse processes of your thoracic vertebrae in the back. And they kind of move on these a bit like turning this bucket handle as you see on the figure in the right. So those muscular changes are going to move the ribs. The other big muscle that is contributing to changes in chest size is the diaphragm. When the diaphragm is at rest, it is dome-shaped, making the volume in the chest cavity lower. When you inhale, the diaphragm contracts and flattens, and when it flattens, it makes more volume in the chest cavity. So we see here those ribs can move up and down based on what we call intercostal muscles that are between the ribs, and we also have the diaphragm. So we're going to talk about quiet breathing first, and it's important to understand the difference in quiet and labored breathing. Quiet breathing means that we are not inhaling and exhaling maximal volumes. It's just sitting at your desk right now, inhaling and exhaling average amounts. Quiet breathing in, quiet inspiration, involves what we call the external intercostals, which you see labeled on the figure in the left here. And what they do is they lift the ribs up a bit, as you can see in this figure. When they lift the ribs up, they make more volume in the chest cavity, and the intrathoracic pressure in your chest falls, so 2 to 3 liters can come in. In quiet expiration, this is actually a passive process. If in quiet force, the external intercostals, which were elevating the ribs in quiet inspiration, and we relax the diaphragm. So it is a passive process with no action. The lungs go back to their original size because they have lots of elastic tissue, and there's also that surface tension that we've talked about in a prior video between the water molecules and the alveoli that help them assume the smallest position possible. So air is pushed out when the dimensions of the chest and lung get smaller, and that pressure rises above atmospheric pressure. So quiet inspiration involves two muscles, the diaphragm and the external intercostals. Quiet expiration is a passive process that involves no muscular activity, just the relaxation of the external intercostals and diaphragm, and the lungs go back to original shape due to surface tension of the alveoli and the elastic recoil tissue of the lungs. In labor breathing, we are going to use more muscles. And if you, sitting at your table, try to inhale and exhale large amounts, you will feel that you use more muscles. So in forced expiration, which quiet expiration use no muscles, but in forced expiration, we're going to use the abdominal muscles to force the diaphragm further up. The internal intercostals also are used in forced expiration as they depress the ribs and pull them down, and you can see those on the figure here in the right. So notice those internal intercostals are only used in forced expiration, not in quiet expiration. In forced inspiration, we will also use more muscles that will pull up the ribs, and those are going to be the sternocleidomastoids, scalenes, and pectoralis minors that are going to lift up ribs 1 through 5 to allow more space in the lung, more volume, so that the pressure can drop lower than atmospheric pressure, and we're going to inhale larger amounts there. So the basic steps involved in breathing, you're going to use the diaphragm and external intercostals to create more volume in the chest to do a quiet inspiration. As the volume increases in the chest cavity, the pressure will drop below atmospheric pressure. When pressure drops below atmospheric pressure, 2 to 3 liters of air come into the lungs. Whenever we exhale, the passive process, the elastic recoil and surface tension, your diaphragm and your external intercostals relax, and then you exhale because pressure gets higher as volume gets lower. Pressure rises above atmospheric pressure and air will flow out of the lungs. You also have this intrapleural space, and you see on the figure on the left, the light blue line represents where the parietal pleura will be, the outside serous membrane, and the orange line represents the visceral pleura, which touches the lungs. And as chest volume changes, the volume inside this intrapleural space, we call it, is also going to change. The pressure in the intrapleural space is always going to be lower, and this creates a bit of a suction to help keep the lung inflated so that those areas kind of pull the lung out. So that's the space between the ribs and lungs. So it does rise and fall with expiration and inspiration, but it does not equalize with atmospheric pressure. It's usually about 4 millimeter mercury less than the pressure inside of the lungs, which creates that slight suction effect. There's also serous fluid or pleural fluid in there, and it's constantly being pumped out of that pleural cavity. So that way it doesn't create too much fluid and it kind of sticks them together. It's a bit like if you have a glass that is sweating at a restaurant and you have a cardboard coaster and you pick up that glass and the coaster is stuck to the bottom of the glass. You can move it around and it slides, but those water molecules in between are going to create kind of a suction force. So that's a bit how the parietal and visceral pleura stick together, and that's how we can relate chest volume changes there at the parietal pleura to lung volume changes as it kind of is glued to that visceral pleura. So here we see those same steps, but with numbers. Atmospheric pressure at sea level is 760. If we start out with it equalizing there, if we have quiet inspiration and we contract the external intercostals and the diaphragm, and that intrapulmonary pressure drops to 758 below atmospheric pressure, air will flow in. Notice we have the equalization there. Then if we look to the figure on the far left, if we quietly exhale, so we are lowering the volume of the chest cavity by relaxing the external intercostals and the diaphragms, notice that the intrapulmonary pressure increases to 762 above atmospheric pressure, so air flows out of the lungs. Other factors that affect pulmonary ventilation are airway resistance, surface tension, and what we call lung compliance. Airway resistance is anything that will impede airflow. This usually is referring to smooth muscle that is in your lower bronchial tubes. In sympathetic stimulation, you get bronchodilation, which you see over to the far left. So smooth muscle relaxes and dilates the bronchial tubes. You get slight constriction of that smooth muscle in bronchial airways and bronchoconstriction in parasympathetic stimulation. Bronchioles enlarge during inhalation due to outward expansion. So that parasympathetic stimulation is going to cause slight resistance, as well as if you had mucus or something lining the insides of those, that would also be something that would contribute to resistance in airways. Surface tension, as we've spoke of before, this is due to the water molecules in the alveoli that are more strongly attracted to one another than they are the air, and that will cause those alveoli to assume the smallest position possible. We don't want them to collapse, however, so you've got those type 2 alveolar cells that secrete that fluid called surfactant, and that surfactant is going to be a mixture of phospholipids and lipoproteins, as you see on the figure on the far right, that mix with those water molecules to cut down on that surface tension so they don't collapse like you see in the collapsed alveoli figure. So surfactant is not produced significantly until the last 10 to 12 weeks of gestation. So many times premature babies will be born with respiratory distress syndrome because they are not producing enough surfactant, and they'll have those collapsed alveoli as you see in the microscope figure there. So that's what causes respiratory distress syndrome in infants. Finally, the other thing that will affect pulmonary ventilation is lung compliance. And by definition, lung compliance is the ease with which the lungs and thoracic wall can be expanded. This usually is due to that surface tension we just talked about. So we don't want the alveoli to collapse, but we want a little bit of surface tension so that when we quietly exhale, those alveoli assume the smallest position possible without collapsing. And also the elastic tissue, which is what that microscope image is for. The elastic tissue should be able to go back to its original shape when we quietly exhale. Decreased compliance could be due to scar tissue in the lungs that replaces some of that elastic tissue, pulmonary edema, which is fluid in the alveoli that causes more surface tension, a lack of surfactant deficiency like we see in respiratory distress syndrome, and something impeding expansion, maybe like a pneumothorax, or which fluid may be in the pleural cavity that is pressing on a lung. So those things will affect the ease with which the lungs and thoracic wall can be expanded. So in general, you want to have high compliance, and you want to have a lower amount of surface tension, and you want to have lower resistance depending on the situation.